All right, we'll call the Central District Health Board meeting, the December meeting, to order. I've asked Corey to do a silent roll call. Good, looks like we have a quorum. Next on the agenda is approving the agenda. Without any objection, we'll approve the agenda by unanimous consent. Any objection? Likewise, with the minutes from last meeting, unless there's any objection, we'll approve the minutes from last meeting. Any objection? Seeing none, the minutes from last meeting are approved. Next on the agenda is public comment period. Are there any individuals present or online that want to comment? Seeing none, we'll move on to the next item, and that is the review of the fiscal year 26 financial report. Laurel, you're up.
Thank you, Mr. Chair. So we are, this report that you have is through the end of the month of November, which is about 42% of the way through the fiscal year. And as you can see by the summary numbers and the rows going across, we're coming in just our revenues and expenditures at 41% for both. So we are right on track and closer than we normally are to budget, which has been a big effort of ours to try to stay closer with both expenditures and revenues. Where you'll see a little bit of a difference from the planned amount is in our county contributions. We haven't gotten our second Ada County payment yet. That usually comes in January or February. So that brings the whole expenditure or revenue column into 37% rather than being at the 41 or 42 that we'd expect to be at this point in the year. I will also point out in our revenue section under community and environmental health, if you follow that line across to the fees section, we are only at 26% of our planned revenue for community environmental health fees. And that is our issue. We're a little bit behind in accounting for those on the finance team. It's our accounts receivable person's first full year in the cycle. We got all caught up in family and clinic services. And now it's renewal season and another new learning curve. So we're a little bit behind there. When I say a little bit, it's actually a big number. It's about 275,000. But that will be caught up by the next time the board meets. So just want to point you out. I know that we're aware of it, and by next year shouldn't be running into these issues with training and staying caught up on our fee accounting. Going down to the expenditures, you'll see support services, capital expenditures were considerably over there, but we put very little into our capital plans this year. Most of that went into our special project planning, which we'll look at on page 3. We've had some HVAC issues, some plumbing issues, just kind of normal stuff. But again, with only $25,000 put into our capital planning, anytime we're over by a little bit, it's a big percentage. So all that out as well. But our big category, of course, for expenditures is personnel. And we are staying right on track there. The board approved planning to spend 90% of our personnel budget rather than the whole 100% this year to be closer to where we usually end up being. And that is so far working out really well. So a little bit of a different approach that seems to be working out for us. Moving on to page 2, you'll see again that fee revenue showing up as a shortage in our food programs, considerably behind where we were for the last 2 years. And yeah, by the February meeting, we should have all of that accounted for in the categories that it belongs in. Also point out in community and environmental health fees, our other fees are quite a bit higher than usual. That's vital statistics and anything that doesn't fall into the other categories. And in that category, some of what we receive we transfer to health and welfare. And we've had a backup on transfers and still have some interagency issues that we've had since we moved to WIPA. So that number will actually go down by the time of the February meeting, and it won't appear as often as it does now. With family and clinic services, you can see our fees are doing really well compared to the last couple of years, especially home visitation. And that's been with the growth of our home visiting programs that the board has supported and an increase in what we can, which families qualify for Medicaid reimbursement. So growth and additional ability for reimbursement is what has caused that big growth there. Going down the page on the left column, our contract revenue is right about where we expected it to be for this year, a little bit behind the last couple years, but as we've talked about the last couple board meetings, we knew there were a couple less contracts we were getting going into the year, so that's where we plan to be. And then looking at the final row of the left column, our total revenues with fees and contracts. Fees are about 16% under, and contracts are right on at 0.2% under. Looking at the expenditures column, again, personnel is very close to where we plan to be. Our operating is over, and that's mostly been due to IT costs. It's expensive, and trying to plan for it can be difficult to do. The vendors that we work with, prices change all the time. We plan as well as we can, but IT costs are what you see there with the operating costs being over. And then TMB, that's not a cyclical one. It depends on when we're contracting with the vendors that we subgrant money to. So that may fluctuate throughout the year. And then, as we talked about on the first page, capital over. Okay, and then moving on to page 3, our cash balance statement. So the top number is what our actual cash balance is, that just over 11 million. I have updates on all of our special projects. So for capital improvement, the office expansion, we met just this past week to finalize what our plan is for office expansion. And the plan includes updating 2 internal spaces for use by home visiting teams and adding additional office and workspace in the west part of the clinic lobby. And then also adding an additional storage space on the premises and removing the old Connex that's out back. So it's actually a usable storage space, which will also free up more office space in the building itself. So we should be getting quotes on that within the next month, and hopefully I'll have more to report. I don't expect the number to go down by the February meeting, but we should have quotes to be able to tell you what we're looking at there by the February meeting. IT equipment support, we have just placed an order for iPads for the building so that people coming in can check in virtually and won't have to continue to use paper forms. So ordered quite a few to support the whole agency and the other 2 offices. So that will show up by, that's not the whole amount, of course, but that'll show up by the time of the February meeting. And then we've also just in the past couple of weeks, signed a contract with a vendor who's helping us transition our paper files into digital, and then our SharePoint transition as well for our existing electronic files that are old shared files. I know this is a lot of details, but it's really cool to be seeing this stuff come to fruition that you have supported. So I'll keep going through. Marketing, we've had some spending there and still have plans for those additional funds. Program support, we still have a pretty big balance there, but we have had some spending. Our CDH staff, for that one, we don't anticipate using as much as we asked for. So we may ask for some of that to be reallocated during the budget revision request in February. We'll keep you updated on that. For training and development, 2 of our divisions have had their day-long division meetings. Support services, my division is still coming up. That'll be in February. And then we've also been able to plan for some of our leaders to go to additional trainings. So that's been really helpful as well. Our vehicles have both been ordered and arrived. That invoice has come in as well. So that will show up by the time of the February meeting. So we received 3 new vehicles. Got them just this month. Retention incentives will also be paid out by the next meeting. And then for capital improvements, I have at the end of this cash balance statement, like we mentioned last time, looking at pictures of what changes have actually happened with this. So I'll show you what our upgrades look like. And then of course, we are continuing to work on implementing Excella. We're looking at March 27th as our rollout date. Right now, we're working on the integrations with our document management system and with our ArcGIS, and getting all of that to come together. in the next few months. And Curtis and his team have been working really hard on making sure all the data is ready to convert and that all the user tests are being done as they're requested. So thanks to you and your team for making that happen. Okay, so that in summary, we've spent 151,000 of the 2.2 million that was set aside. So we still have pretty big balance of our special projects money. We'll keep tracking that, and especially on the staffing, maybe asking for some reallocation during the budget revision. The reserve fund amounts remain unchanged. So with our total reserve fund designations, we've got 7.5 million there, and then 4.3 about in restricted funds, which brings us down to that negative number at the bottom of the page of 775,000. And we've seen that amount fluctuate over the past several board meetings. I hate to look at a negative at the bottom of this page, but then I look back up to the top of the page. Remember that our actual cash balance is 11 million, and that's includes, all the special projects that we plan to spend throughout the whole year, assuming that we get all the money that we plan to throughout the year. So all the 2 million that's listed as remaining balance, of course, is still our remaining balance. And the rest is all just money that we set aside. So we have this money, we just have it earmarked in a way that is with the negative at the bottom. Once we get the Ada County payment in and our fees, that won't be there. Of course, we wouldn't spend the special projects money if we didn't receive those. So it's not a true negative, but still looks unhappy there at the bottom of the page. Any questions on that before I pull up the slides?
Maybe a little bit of an in the weeds question, but you mentioned the iPads. Do they require a separate software, or is that going to integrate with software that we already have?
Mr. Chair, it does integrate with the software that we have. Our IT team has actually built some apps that we use on our check-in software. So some of the forms they've built as digital forms that automatically go into the systems that we use them in. There's no new software that's needed for the iPads to work the way that we plan them to. They'll integrate well with Excel when we have those customers coming in to each of the offices to fill out their applications and stuff digitally. And so no new software needed. Also want to point out that for people who prefer paper applications, we will still, of course, meet them where they are. We're not going to be requiring 100% of customers or staff to go fully digital. It just allows us to modernize and work at the pace that our teams are moving.
Good. Okay. Very good. Thank you.
Mm-hmm. Dustin, if you could pull up the PowerPoint with the before and after pictures of facility improvements. Thank you. And so this is just a few. Go ahead into the next slide, please. A few pictures of what we've done. So this is one of the things we did over the past calendar year. Oh, go back one. Probably see this when you're parking in the parking lot, unless you're pulling in the dark, which you might be now. So new wicks that we always have people going in the wrong doors and having to ask for directions. So we're trying to get as many visual just signage and making it as obvious as we can where people need to come for WIC and clinic services. So new sign, that's one small thing that we have for the Armstrong building. And then we can go to the next slide, please. So this is a before and after of the Mountain Home roof that was approved and part of the Mountain Home upgrades. Okay, next slide. And then we also did upgrades to the front of the Mountain Home building. Don't have before pictures here, but we had some like what are they called? Well, that was over the windows on the Mountain building. Yes, we had some old awnings over those windows that looked ancient. The grass was patchy, weeds. There was even a time a few years ago when things had blown into the grass that nobody really cared about it because the whole front wasn't looking great all the time anyway. So it's been really a priority to get it looking as professional as we want it to and be able to maintain that. So new tree, full new grass out there. We removed some of the old, we had some signs along the parking area there. So totally new look to the front of the Mountain Home building, which we're really happy with. And then we can go to the next slide. So this is the accessibility ramp in McCall. For those of you who are here for the budget meeting that we did there a couple years ago, it was literally crumbling apart down where the railing was. So we totally replaced the railing and the concrete itself. So it's now safe and looks better as well. Next slide, please, Dustin. So I don't have many like before we completely started pictures. We didn't do a great job of getting those, but the picture on the left is the color and the old carpet that had been there for decades. And that's some of the decorations that we had in the office. This is kind of in progress as they were pulling everything up and getting the work done. And then we can go to the next slide.
We didn't get rid of those curtains, did we?
Those curtains may not find another home. I can see if you want them up and set them aside.
All that retro stuff is now not so retro.
That's true. That's right. So this is the new carpet and the lighter paint color and the new furniture that we got in there for our staff. I don't have a full good picture of what the whole thing looks like, but it's just night and day difference from before. The staff love it. We've received positive comments from the public. It's a totally different feeling walking into that office. So we really appreciate having the special project funds to be able to do that. In fact, now that we've got this done, they're looking at some of the old linoleum in the exam rooms that were there from before and have requested the rest of it to be brought up to modernized as well, because it's made such a big difference just to walk in and see this every day and be happy in the workspace and comfortable in it. I think that's the last one. Yeah, so those are some of the projects that your special project allocations have allowed us to do. So we're really thankful and appreciative of that. That's all been in the last calendar year.
Then are we moving on to strategic plan? Okay, Laurel, you're up again.
Okay. So move right into strategic plan. Thank you, Mr. Chair. Dustin, there's a slideshow for this one as well. We're not seeing it yet, Dustin, if you're getting it pulled up. Thank you. Also, thanks to the communications team for the lovely new PowerPoint templates that these are new too from what you've seen before. Okay, we'll go ahead and go on to the next slide. So we're just going to go over a few things about how we put our strategic plan together, what's in the plan, and then our timeline and next steps. This strategic plan goes from calendar year 2026 through 2028. And it's a little different than the last version of the plan that we had in both how we put it together and the content. So we'll be looking at that next. You can go ahead and go to the next slide, please. So we started several months ago with an in-person meeting with all of the leaders in the agency. We broke them into groups and talked about what was happening in their programs, what they saw as threats or opportunities, or where we could continue to grow in the communities, where there were gaps in our services. We also talked a lot about what Russ's priorities were and just where do we need to be focusing for our strategic plan to actually have meaning to our team. And we did that with, again, all the leaders in the agency. These are some of just a couple snapshots of the huge poster boards that we had up all over the room, which had pages and pages of stuff that people wanted to work on, and a lot of alignment. We found even if people weren't working in the same program, they still saw the same priorities for the agency, and those also align with what the board has earmarked as priorities as well. So it was kind of nice to see it all come together like that. So we did a data review, again, talked about priorities, and then really thought about how can we offer our services where we're not duplicating what other agencies are doing, what's going to be financially well-resourced and sustainable, and what does our community really need. So we tried to put all those things together and came up with the 4 goals that are on the next slide. Not quite on the next slide. One more slide. So there we go. 4 strategic goals. We had 3 before that were somewhat similar to this, but we added a 4th one this year. So the first goal is advancing our programs and services, community aligned, vision driven, and sustainably resourced. We still have a customer service related goal. We want it to be exceptional, innovative, responsive, and accessible to our community. We also want our staff to have the best tools and resources available to do their work and to do it well. And then we want to make sure that we're being transparent with our funding, optimizing the funding that we do have, and that our funding matches what our strategic goals are. So that's what that 4th goal is about. We can go to the next slide. So under goal 1, advancing our programs and services that are community aligned, vision driven, and sustainably resourced. Want to, in some ways, I'm not go back to the drawing board, but really analyze what our programs are doing now and if it works the way they're doing them. So with WIC and Clinic, we want to do a review of what our hours are, how are our walk-in clinics working, should we be having after hours, after 8 to 5 office hours available for clinic walk-ins and WIC, or does it work the way it is now? Does it match what our community needs are? We also have recently opened our Idaho City clinic and realized that in Valley County and Elmore, those core clinic services are provided elsewhere. Haven't been able to build the customer base, but how can we work with our partners that are already providing it to make sure that our community's needs are being met? And then in Idaho City, where there isn't a clinic, we can be there on a regular basis and provide services that aren't being provided in the community. So this is about making sure we're doing the right programs in the right communities, not duplicating, and that we can continue to do them in a way that makes sense. Okay, next slide, please. Goal 2 is about customer service. So we want to make sure that our customer service platforms are modern. We're not using old paper-based processes, and that our customers aren't forced to use those either. We want to look at our EPI processes and again, eliminate the reliance on physical and paper records there. Our IT team has also been working on developing an oral health app so that parents can digitally allow their kids to participate in our oral health clinic in schools and eliminate those paper registration forms. Right now, when we get those in, we're having to do a duplicate data entry 1 or 2 more times, depending on how they come in, because it's all paper-based and transferring person to person to get into the right system. So save time, money, and paper through that. And then continuing to monitor and improve our customer satisfaction metrics. Some of our programs automatically send customer service surveys out after they've been in to see us. Those are always high, but we don't have them across all of our programs. So we'd like to expand how we're using those. And then we also want to be ensuring that our staff really understands how and what good customer service is. Sometimes it's kind of assumed that people know that coming into customer service roles, but we don't regularly train on that, or we haven't in the last several years. So we want to make sure we're training all of our staff to understand what customer service is and how to provide it well. Okay, moving on to goal 3. Oh, one more page of goal 2. A few more things that we have under this one. So expanding accessibility, improving the percentage of patients using self-check-in, that the iPads will support that. And then also making sure our food safety material is available in multiple languages. That's one set of documents that we haven't necessarily met our community need in having them available in multilingual formats. And then as we've talked about with our opioid funds, expanding access to our use of, or to our risk reduction resources as well through the things that Courtney's presented on and Becca's team have talked about. Now moving on to goal 3. So this is our goal that's related to the technology and tools that we use mostly internally. Again, having that professional development available to make sure the staff know how to use the tools that are available. Onboarding and training for new staff, including program overviews and specialized topics. Our internal systems, making sure that they meet the needs of what I guess most people are doing now for clinic services and for environmental health services. Excella is a part of this goal as well. And then one thing we haven't done before that we want to do with this iteration of the strategic plan is to develop a technology roadmap so that, and that's something we could share with the board as well, but so that we're planning where we're going and not just being responsive or reactive to upcoming needs, that we really know, 5 years, where do we want to be technologically. So that's something the IT team will be working on that they haven't done before. And another thing that came out really heavily in our in-person supervisor meeting was that a lot of programs internally don't necessarily know how to support each other, what their other programs are doing in the community, and how we talk about that internally. So we're working really hard to enhance that collaboration internally, so we know what we're doing when, and we can make sure our efforts, even among our own staff, aren't duplicated. Moving on to goal 4. And this one's the last one that we added, that's really about our funding and our transparency. And that's making sure our budget matches all of these priorities we just talked about. We'd like to recalibrate our environmental health fees to cover more of the program itself. So when we come up for fee approval time, we'll be talking to the board more about that. Updating our opioid settlement fund plan. We put a 5-year plan together as we started to get the influx of those funds, but it's time to look at that again and make sure that it's updated. Again, that streamlining and digitizing. And then we also added a couple objectives under strengthening our internal budget management and making sure that program managers know how much they're spending, what they're spending on, where there are gaps, and that we're communicating that regularly internally so that we're staying closer to those budget marks that we want to. Okay, and then the last slide, just a summary. So really, this is what we're trying to do through our strategic plan. Programs and program growth should match our vision, the board's vision, and what the community needs. Continuing to improve and modernize, and then using technology tools and resources to do our jobs effectively with the level of transparency that we know the board expects and that we expect of ourselves. That should bring us to this next steps. So what we're doing next is finalizing our metrics. So that's the content of the plan. Now we need to look at how are we going to show that we're doing this successfully, and what exactly are we going to be reporting on. So we hope to have that finished up in the next few weeks. The division administrators have been working with their program managers on that over the last month. We also had Ed Castro come show you our last strategic plan dashboard several months ago. He's just beginning work on updating the dashboard to match the new metrics that we already have, and then we'll be adding the ones that we're finalizing after that. And then another thing we instituted this year is that we're doing quarterly meetings with all of our supervisors to let them know what our progress is on the strategic plan. So we're keeping it in front of people, and it's not just something they can, go to a link to on the internet or on the webpage. We really want to work harder to keep it in front of people and keep our progress in front of people. I think that brings us to questions or a summary slide. So, and for any questions that you might have or any discussion about that.
Any comments, thoughts? All right.
That's awesome.
Thanks.
It's so much easier to follow and to see progress. That's exciting.
We feel that way too. The collaboration this time has been and felt different. I think, it's testament to how the board has supported the staff and getting our retention rates are high. We've been having great applicants anytime we do have a new open position. People are engaged. The engagement that we had at the supervisor meeting was something I hadn't seen before as we've worked through the past versions of the strategic plan. So when we say thank you for the support of the projects and what the board has done for our staff and the retention incentives, it makes a big difference and it leads to outcomes like a strategic plan that works and makes sense and people are excited about.
Personally, I like the idea of really, tracking metrics and making sure we're getting bang for the buck and not just going through motions and having positive outcomes.
Right.
We're seeing in our society right now that a lot of what's been going on in the healthcare world hasn't been fruitful. We're a sicker population spending more money and monitoring metrics and making sure that we're dialed in and making an actual impact, I think is super important. So, very good. Thank you. Any other thoughts, comments from the board?
Thank you.
All right, well then I think we're on to Curtis and a conversation about swimming pool safety.
Mr. Chair.
Yes, Curtis.
Thanks for letting me talk about pools once again. I know we've had this discussion a couple different times, but we're excited to be able to present to you today kind of some thoughts on what we would like to do and where we would like to go with pools based on the things that have happened recently. So I just wanted to touch base on a little bit on the past, on what's occurred and where we've been with pools. And then we've got Natasha Fernie here with us, who is our program manager in environmental health from our facility-based programs. And she will be able to talk about some of the things that we've done historically with pools and help provide some information on what we would like to be doing in the future. So, all right, next slide, please, Dustin. Okay, so historically, Central District Health, we typically inspected somewhere between 150 to 200 pools annually. And this was back in the 90s and the early 2000s. So pools were broken down in Idaho into two different groups. Type A pools are the pools that are typically publicly funded, municipal pools, open to the public, stuff like that. Type B pools were semi-public pools. These are things that are found in places like gyms, hotels, HOAs, apartments, different facilities like that not are as accessible to the public, but still have a wide variety of people using them. And we inspected all of those, or like I said, around 150 to 200 pools annually. Then in the late 90s and the early 2000s, the state legislature made changes and we reduced the number of pools that were inspected by health districts. We eliminated the type B pools and we were limited only to inspecting type A pools, which again are the municipal public pools. That brought our 200 pools annually down to about 36 to 38 pools that we inspected on an annual basis and licensed for use within the 4-county area. Next slide. So that was the first major change that occurred with pools. We've been operating under that for quite a while now, inspecting those 36 to 38 pools. And I'll let Natasha talk about what that inspection process was like and kind of what our goals were for that inspection.
Sure, thank you, Curtis. So Central District Health Swimming Pools Program was responsible for the permitting and regulatory oversight of public swimming pools for years and years. We inspected pools, issued licenses, and provided technical support and educational support to pool operators concerning various of issues such as waterborne illnesses and other concerns. So compliance with ADAPA rules governing construction and operation of public swimming pools in Idaho was always our primary emphasis and primary focus. And of course, with the primary goal of prevention of illness, injuries, and death. So, and as was mentioned by Curtis, In the prior slide, facilities-based programs, my team worked with anywhere from 36 to 38 public swimming pools within our jurisdiction every year. Majority of aquatic facilities we worked with are in Ada County, including those that voluntarily went through licensing and inspection process. For instance, 6 pools within Roaring Springs facility was inspected and regulated by us for years. Expansion project. So per ADAPA, each public swimming pool was required to obtain a license and renew it every year. And since pool license was effective for a calendar year, renewal process for swimming pools was very similar to that for food establishments. For example, renewal notices would be issued to swimming pools. They would require to fill out a renewal application, pay a permit fee, and provide us with the proof of current certified pool operator certification and CPR and first aid. So those were kind of additional requirements that we asked for. So each regulated swimming pool was a subject to one unannounced on-site inspection. Every year, environmental health specialists would check the facility for compliance with 43 items based on different sections of the ADAPA, such as health and safety, water quality, operations, mechanical, and construction. If a violation was observed by an inspector during an inspection, then a follow-up would be issued if a violation wasn't corrected on site at the time of the inspection. It was always our priority to inspect swimming pools at the beginning of their operational season. For example, last year, Boise municipal pools opened up at the end of May, and we made sure that those inspections were conducted first 2 weeks in June. So that was kind of a seasonal work for my team. We also conducted plan reviews for new and remodeled swimming pools. A plan review process would typically include review of architectural plans for the proposed facility, discussions with construction leads, facility designers, future operators. That plan review would typically follow up by pre-operational inspection, and then would receive regular inspection within 30 days of their opening. So we would always encourage installation of supplementary inline disinfections, disinfection systems such as ultraviolet light and ozone. Both are proven to be very effective against cryptosporidium and would improve water quality on a daily basis alongside regular filtration systems that are in place at the facility and disinfection protocols that are implemented. So we always advocated for the most current technology and design features during plan reviews. As previously mentioned, education and technical support was a very important part of the program. Over the years, we provided a number of educational resources and materials. We distributed water chemistry testing and treatment guides. We distributed information on various waterborne illnesses, information on mitigation of various hazards at the pool that can happen at the pool. For example, mitigation of fecal and vomit incidents. We talked to operators about strategies to improve indoor air quality within the facility. We also developed a self-checklist for operators that they can utilize on a daily basis or weekly basis when regulatory authority is not there to help them. Then they would use the checklist to make sure that they're staying on track of the best practices and protocols. Here at Central District Health, we offered swimming pool course that would help operators get familiar with the Idaho swimming pool regulations. So although the rules, ADAPA rules are no longer enforced, ensuring healthy swim environments is still a priority for my team, and environmental health specialists actually remain available to provide any type of technical support or educational support if requested. For example, like I mentioned, prior to July 1st of 2024, we started working on the plan review for the expansion of Roaring Springs, and we continued communicating with Roaring Springs leadership and construction leads to ensure that everything is going smooth. And I visited the facility about 2 weeks ago and provided City of Meridian with a little overview and said, yes, they're on track, everything's going well. So it is needed. So our involvement is needed. So it is our hope that we can utilize the experience that we gained over these years and expertise to hopefully continue educating pool operators in the future. We have a few ideas what this may look like, and I will let Curtis speak to that.
All right, thanks, Natasha. That's a great overview of kind of what we've done in the pool programs in the past. As Natasha mentioned, the IDAPA 160214, those regulations due to the legislative actions are no longer enforceable. We can't require anybody to comply with those at this point in time. And so where does that leave us moving forward into the future with pools? Well, we've developed, and Dustin, you can go to the next slide. We've developed some ideas on things we would like to do in the future. Again, our emphasis will continue to be to educate, provide technical assistance, train, and consult for type A, and we'd like to include type B pools in that as well. If you can remember the difference between the two, type A being municipal, type B being the less public, more private pools, gyms, hotels, HOAs, apartment complexes, stuff like that. Our goal continues to be to prevent illness and injury and promote health and a healthy lifestyle. We would like to accomplish that through two things. One, we would like to provide a certified pool operator course similar to what we've done in the past. This is something that we do with our food operators as well. We hold a certified food operator course where food establishments can send their key personnel. We teach them the ins and outs of food safety. They then go back and as part of their operations, they implement that education and training that we've provided them. And then we go and provide technical assistance to them as needed to help prevent injury and illness in the food establishments. We'd like to implement something similar to that in the pool world, where we are offering a certified pool operators course where we can bring pool operators from across the 4 counties together. We can provide the education and the training through a certified program and be able to provide them the consultation and technical assistance that they would need to be able to successfully run a recreational aquatics facility that also focuses on the prevention of illness and injury. The second component to that is we would like to provide a technical assistance program. This would be a fee-based tiered approach where we would be able to market to the different entities and pool operators throughout the 4 counties. We would be able to approach them and say we've got some different technical assistance consulting packages that we would like to be able to share with you for a fee that is merely built to cover our cost. We can provide yearly inspections, we can provide technical assistance, we can provide consultation on helping them focus on illness prevention and injury prevention as well. And working through some of that technical issues that we want to be able to advise them on. We'd like to provide comprehensive site evaluations, as well as regular on-site in a non-regulatory fashion, because we're not there to regulate anything or enforce anything, but really be there as a technical guidance and educational expert and someone that they can lean on when they've got technical questions about the best way to operate a pool. As well as the development and dissemination of all of the information and educational material that we have. So that's kind of the approach that we would like to take. It was really education focused, training based, and really working with our pool operators to help them become better educated, certified, and more knowledgeable in the safe operations of pools. We would like to offer that consultation package to both our Type A and our Type B pools throughout the region. So that is kind of our plan moving forward. Next steps will be to really develop what the different tiers might look like. I think we'd like to have a fairly comprehensive one where we offer as many services as possible, probably comes with a higher fee. And then maybe a lower tier where we're offering slightly less in terms of the number of annual visits, the types of training that we're offering, but it comes with a lower fee as well. So the pools have an option on the kind of things that they would like to engage with us at the level that they would like. And again, those fees would be developed and based off of our current fee policy that CDH has, where we would basically look at the amount of time that we're putting into it and what we anticipate that cost to be, so that we can just cover our cost. It's not a money-making endeavor, never has been, and we don't intend for it to be. So that is kind of the direction that we would like to head with our pools, and would like to just open that up for questions or comments or concerns from the board and get your take on that. Chair.
Are there any county-owned pools, or are they all, as far as the Type A municipal pools, are they all city?
City or rec districts. Yeah, ours is a rec district.
Okay. Does the county oversee any of the rec districts? I guess what I'm getting at is who's the decision maker in these municipal entities to implement something like that?
Yeah, Mr. Chair. So our working history with these pools has been very, very good. So Natasha and her team have worked immensely with these municipal pools, whether they're city-owned or rec-owned or voluntarily engaging with us, such as Roaring Springs, the Wise, all of these different pools we've developed over the years. Great relationships with these, with their executive leadership teams. They trust us. They come to us with questions and technical assistance, and they know that we'll be there to help educate, train, and promote health within their organizations. We anticipate that relationship to continue. They're also accustomed to paying us a fee to come out and license them every year. As we develop our new consultation package and similar fees to be associated with that, we'd like to work with our communications and marketing team to market that across the 4-county area to our municipal pools who are already engaged with us anyways, as well as those Type B pools who have been less engaged over the years, but we hope to get more engaged, and really working to offer that with them. So our plan is to continue to work with those that we have worked with traditionally for the Type A pools, and really heavily market the Type B pools and try to engage with them with the intent of offering training, education, and consultation for the low price of whatever fee comes out to be, and providing that service to our community, and making our recreational aquatic facilities across the 4 counties the safest that we can get them to be.
Well, and so ultimately it's a voluntary, pitch. I mean,
Correct.
we're trying to remarket, here's our service, participate. And I think that's a good idea. And they get to set themselves apart from others that maybe don't. They can publish and market their certified pool, their inspected facility, and that type of thing.
Quick question. Do they get an insurance break if they have certified or gone through the course?
Yeah. Mr. Chair.
I do believe so. I do believe so, yes, seems, good selling point.
Yeah.
When you pitch it.
And that's something that we would like to really know and understand so that as we develop our marketing, that we can go to these, especially the type B pools that are less inclined or haven't worked with us in the past and offer them, these are the benefits of allowing us to come and work with your staff and teach and train and educate so that you can then achieve the certification that allows you to get a break on your insurance and all these different benefits.
Sure. Does it open CDH up for liability for those that voluntarily do it and say something goes awry and something's unsafe at their facility? Does it open us up for any to be, I guess, responsible in that manner?
Mr. Chair. I don't believe that it opens up to any further liability than what we have assumed in the past, or any different liability than what we assume when we do the same type of training, education, and consultation with food programs. And then our goal would be to help educate and train to prevent those, with the real liability playing with the establishment owners and operators that are operating those establishments. We'd be happy to research that, consult with our legal counsel if needed, to make sure that we're not taking on unnecessary risk, or that we're covering all of the information that we need to make sure that that's not a concern.
You take a fee, then all of a sudden.
Yeah. Your point is well understood, and we would certainly do our due diligence to make sure that we are operating in a way that we don't incur that risk.
Question, do you know an estimate on how many type A and B pools there are, and if all of them start voluntary going along with this problem, will you require additional staff?
Mr. Chair.
Yes, Christine.
Awesome.
We have that information actually, and our wonderful public information team did start a list of potential facilities that we can contact. So far, within our jurisdiction, we're close to 90.
90.
90.
Mr. Chair, quick question. Does your team have the capacity if all 90 were to come on at once?
Well, I think we should have. So I don't anticipate every single one being on board right away. So hopefully this will be more of a gradual development for us. And tackle it.
Mr. Chair, I would just add, yes, we do have very qualified staff to be able to conduct this business. They are engaged in other work as well. They're heavily involved in our food programs, in our child care facility programs as well. This would definitely mean a shift in some of our workloads. Again, that fee that we talked about developing would help to offset the cost if additional staff were needed. That would be taken into consideration in the fee development process, and as more staff are brought on, it would adjust that fee. Again, the fee is intended merely to cover our cost. We're not looking to profit off of this. We would like to cover the cost of our staff time, our operational equipment, and the things that we need to be able to conduct the job and the consultation effectively.
One more quick question on the certified pool operator course. That's a free course.
Mr. Chair.
Curtis.
So there is some costs associated with that. First and foremost, we would probably need to get all of our staff certified so that they were kind of like through a train the trainer type of program, where we would pay for them to be trained. They would then in turn would be certified to teach and train that course themselves. The way we currently run this with our food system, we do charge a fee. I believe it's $115 for a food establishment to send a food operator to our course. It's a full day course. At the end of the course, they take a test. They pass the test, they then get a certificate that's good for 5 years, that certifies them as a certified food operator. The way that I've envisioned our certified pool operation course working is very similar. We would certify our staff, they would then teach the course. Pool operators could send their staff to that course for the low price of whatever that ends up being. And we would then certify them, and they would then go back to their operations and they would implement the things that they've learned at their establishments. And then they would have us for a consultation team for technical assistance, should they have questions, concerns, or need help with anything.
Mr. Chair, and typically certified food protection. uh, Certified pool operator course is certified through National Pool and Hot Tub Alliance. So we would need to be certified as instructors through that organization to provide the course. And there is a fee associated that I do believe covers also an educational packet. Whatever books that come with that, pamphlets, you name it, should be covered.
Just comment, I really like what you folks have done. This is, I think, very good. It's the best we can do, considering there's absolutely no interest in legislative oversight. So kudos to you guys.
Mr. Chair, just a comment if I may. I think this is one of the very interesting things about serving on boards like this. This is something that the average person doesn't even consider when they go to a hotel or to Roaring Springs about the safety of the water. We actually just had a friend that returned from an international trip, and I understand that's international, but she was actually hospitalized after swimming in a pool that was not clean. Went septic with a strain of E. coli just from a scratch on her leg. And it was pretty serious for a while. And I think that's something that is overlooked a lot. So I appreciate all the work that you guys have done.
Yeah.
And it's going to take a lot of work on your guys' part to get the word out there. But I think just as you said, it's a huge safety issue that's really being overlooked. Very important. So thank you.
Been through the CPO course and it took me a long time to get into a public swimming area after the course.
It's a little bit like when you serve safe. You're like, am I ever going to eat out anywhere? Nope.
All right, any other comments? Well, I think it's a very reasonable direction to go. Impressive game plan. There's no action item, so I'd say let's see how you can unwrap this.
Appreciate it. Thank you for your support.
Thank you.
All right, we good on pools? All right, next up, we're going to have Becca introduce a conversation about communities for youth initiative.
Yeah, thank you, Mr. Chair. While Heather gets set up, she's going to be doing the presentation. I just wanted to remind you of a presentation I did earlier this year. We talked about the opioid settlement fund and sort of the 3 buckets we were putting that money into, and one of those was specifically for upstream prevention for youth. And during that presentation, we had a very, very newly forged relationship with Boise State and Communities for Youth. And so Heather's here to provide an update on that. Heather's been with CDH for about 3.5 years and has always worked in youth substance misuse prevention. She came on under another grant we had through Office of Drug Policy, and with the opioid funds, we've been able to keep her on full time and start doing this work here on the Boise initiative. So she's one of the few staff members that's paid fully with our opioid settlement funds, and she specializes specifically in youth substance misuse prevention. And she's an excellent archer if you have any questions about that after the presentation. So I'll turn it over to Heather Allen.
Thank you. Thank you, Mr. Chair, members of the board, for having me on today. I'm excited to talk to you about upstream prevention and just how we can focus that on making the best possible communities for our youth. We're primarily focused on youth well-being, so excited to talk to you about that. I'll give you a brief overview of what Communities for Youth does, and then we'll get more detail about how that looks in our community specifically. Next slide, please. So Communities for Youth is a statewide initiative. We're we're proud to partner with organizations across schools and, well, I'm a partner across organizations and schools in Idaho. I will use we and Central District Health and Communities for Youth interchangeably. I feel like I'm presenting both and each singularly sometimes depending on who I'm talking to. Next slide, please. So currently, there are 10 regional initiatives and 33 schools are partnering and participating in the Idaho Youth Wellbeing Survey, which means that this year over 13,000 students were surveyed, all the way from Lewiston to Aberdeen. And the collective efforts, that collective effort of that many different students is helping us understand and improve that youth well-being statewide. Next slide, please. As Becca mentioned, Communities for Youth is, well, you may have heard about the work that Communities for Youth is doing throughout the state, but also what that might look like in connection with the opioid settlement funds and how they're being used to fund that upstream prevention. So the CDH partnership is one of the ways that we're using those opioid settlement funds, and we're coming alongside the Communities for Youth specifically as the Boise initiative. So Communities for Youth goal is to be a full support capacity builder, and then they help communities become independent in sustaining that upstream prevention. Next slide, please. This is kind of a busy slide, not my favorite slide, but this is our goal and how we, this is what we use to guide our work. We aim to promote the programs and initiatives that promote the most well-being for the most people. So our efforts primarily focus on that fourth tier down. And this is where we can collectively have the greatest population impact. And we feel like by focusing here, we can take some of the pressure off of that top tier, individual support, those counselors and educators. They have enough on their plate already as it is. So by focusing where we are down towards the bottom, we get the most bang for our buck there. Next slide, please. As you are well aware, I'm sure, Idaho faces significant challenges in mental health. Over half, 52.5% of youth in need of mental health services go untreated each year. And Idaho ranks 50th nationally, with a suicide rate nearly double the US average. 2/3 of youth with depression are not receiving treatment. Next slide, please. Teen depression rates vary widely across the state, everywhere from 24 to 67%. And in comparison, the national average is about 20%. So as you can see, these numbers indicate that urgent need for addressing. Next slide, please. The urgent need for Communities for Youth is thinking about what is the right intervention to the problem. So this is why we need to look at the scope of the solution, and the scope of our solution must match the scope of the problem. Clearly, as you can see, this Q-tip might clean up a little bit, but these boys are not going to be cleaned up by one Q-tip, and it's probably going to take several. So we need to make sure that we are using comprehensive community-wide approaches and not just these small fixes to address the challenges. Next slide, please. This is why we believe that upstream prevention is the right scope for the problem. Upstream prevention means working on root causes before those crises occur. It's about increasing the protective factors and decreasing risk factors at the community level, creating conditions that support youth and not just relying on that crisis response. For youth mental health and well-being, that means creating community conditions that support young people rather than relying solely on mental health clinicians or our schools or that crisis response. Next slide, please. So that all sounds great, but how do we do it? This is actually, we're going to use the Boise initiative for context. We have a 5-year commitment we have a 5-year commitment with Boise leaders to move through this process as you see it. And this is what we mean when we're talking about a regional initiative. Those communities have come on and support and committed to being a 5-year community. So our process starts with building a community coalition. And when we say community coalition, this is pretty much you care about kids and what's happening to kids. We want you to be a part of this. Doesn't have to be any certain person, any certain organization. You care what happens to our kids. We want you at the table and we want to hear your voice. Moving to the next one, we center the youth experience and we do that by surveying. So we want to hear from them. We often tell the students and tell the youth that we're using what they provide in this survey data to amplify their voice and to really use what they're telling us and translate that to adults. How can we help them? This is what they're telling us. So the data-driven engagement helps us get those goals or set those goals and then take action. And then we keep the conversation going. You can go to the next slide. So as I said, this is a 5-year commitment and this is a cyclical conversation. So every year we survey. Surveys are vital. They help us understand the issues, as I said, but they also help us check our work and keep those voices of the youth front and center. And as I said, we are very interested in addressing and improving the root causes of what's happening with our youth. Next slide. The survey measures, as I said, those risk and protective factors, but we measure at each of these levels. Survey addresses each of these. So by assessing the risk and protective factors across the communities, the schools, families, peers, and individuals, we can help build capacity and sustain attention on what matters most for what we're seeing in that data. And we all know that our mental health is impacted at all of these levels. So the beauty of this data is it allows us to diagnose, in light quotes, diagnose the community and not the individual. And then evidence shows us that this works. Next slide, please. As I said, the process is on an annual cycle and the process doesn't change. So after 5 years, each community should be able to run these 4 steps independently. As we're building the capacity at all of the levels, it allows us to focus on continuing to build in those protective factors and decrease the risk factors in each community. And we say this all the time, but everybody plays a part in this at every single level. We've got parents who are coming and listening to data sessions where they're learning what is that their youth are addressing. Or we have grandparents coming in and figuring out that they could be a positive mentor. You know, they don't have kids at home anymore, so they're going into schools and being a mentor. Coaches, we have business leaders in the community who have heard our youth voices telling us that they don't feel like they have spaces that they can hang out. So our youth or our business leaders are coming in and saying, how can we create friendly spaces for our youth and what can we do to support them? So again, there's a way that anybody can come in and do their thing and just it collectively creates a pretty amazing impact. Next slide, please. So this is what's great. We can see that the evidence shows that it's actually working. So in Boise, as you can see, these are Boise rates. From the first survey that we did in 2022, the rate of depressive symptoms was 38%, and in 2025, we're happy to say that it's down to 16%. Next slide, please. Oh, I will actually say in our rural communities, on that specific on the depressive system or depressive symptoms, in our rural communities, we're actually seeing an even greater drop. Like in Marsing, for example, they started surveying in 2021, and their depressive symptoms number was 68% of youth reported feeling depressive symptoms, and they're down to 22% for the 4 years. So that I think is pretty phenomenal.
And excuse me, Heather, if that rate is totally based on what the kids' feedback is, right?
Mr. Chair, the rates, it is self-reported. So the students are self-reporting. The way that they measure those rates is based on the PHQ-9 scale, as maybe some of you are aware of. PHQ-9 scale is the scale that you would, it's a survey or a risk assessment that you would take when you go into a physician's office. They would do this risk assessment. Based on that risk assessment, these students would be probably referred out for care. So the students who measure high enough on that PHQ-9 scale would be referred out for care because they've got clinically significant symptoms. Does that answer?
I have a question. When I look at that slide,
Going back.
no, this one right here, I see maybe a couple of missing bullet points in fitness and nutrition. I think the research is abundantly clear that the lack of those has an unbelievable impact on psycho-emotional health. And from a national level, there's a move to reinstitute, for instance, the president's fitness. Are we, through this process, addressing that aspect?
Yes.
Thank you for asking. I've got Megan Smith on the call with us. Megan is she is the executive director for Communities for Youth, and she's also an associate professor, I believe, at Boise State. So she can answer the direct questions about what's being. Can you answer that, Megan?
Yeah, we are measuring physical activity through a couple of different things, and those are represented in the model. And it is a part of the story. It's just not one of the top 6 factors that you're seeing here on the slide. So physical activity is measured a couple of different ways. One, through sports participation, extracurricular activities, and then also just how much time spent physical activity every day. And so we do measure that. We just started measuring nutrition, and not all schools are opting into that measure at this point. So we'd love your advocacy around that to help schools see that that's an important question to include. So thank you.
Mr. Chair and Heather and Megan, as I understand it, the #1 social determinant for public health is lack of housing. Does this include that issue at all?
We get at that a little bit. So we have a not lack of housing, but we have a food insecurity and also a who you live with in your household, which kind of gets at that. It's not exactly homelessness. The reason we don't ask it is because schools say that they have that information already about their young people. So it's a bummer we can't measure it in the same survey, but in an effort to keep the survey as short as possible, schools have asked that that question be left off.
So in this slide, one of the things that we're looking at, we are looking at those key factors affecting youth. And so while the rates of depressive symptoms among the Boise teens have decreased over time, key factors such as these, like social isolation and stress, still impact youth statewide. We see that across all communities. And then in the most communities, lack of sleep and lack of family support also rise to the top. And this year in Boise specifically, dating violence and discrimination are showing up as key factors. And when I say discrimination, the 2 that are most likely indicated for discrimination are appearance and hobbies and activities. So youth are reporting that they feel discriminated based on those 2 things, appearance and hobbies and activities. And so that's a question on the survey where they're able to select all that apply to them. And those are the 2 that we see rising to the top, hobbies and, or appearance and hobbies and activities. Next slide, please. And so we're making progress across Region 4. We're excited about it. We are providing upstream prevention trainings, new partnerships, and ongoing collaboration in Boise, Elmore Valley, and Ada counties. And so each community, as you can see, is taking steps to support youth well-being. And where we could really use your support is advocating for those youth surveys in schools. It's the Idaho Youth Wellbeing Survey. That's something that the more data we receive and the more students we have participating in those, the more we can really amplify those youth voices and those youth experiences.
Mr. Chair, quick comment for us that I think have a pretty good connection with our school boards. Would it be possible to send us an email with all of this info so we know exactly what to talk about, how long the survey takes, so that we're informed before we go talk to the stakeholders?
Absolutely.
Sorry, Heather, go for it. I was like, yes, that sounds awesome. We'll do that.
Do you have specific, specific resources that you can send to anybody that's interested in having that conversation, correct?
Yes, there's lots of resources already available online at communitiesforyouth.org. But when you click on the Idaho Youth Wellbeing Survey, there's some resources there. But we are also happy to template an email with you with like just the bullet points.
Thank you, Megan. Next slide, please. So as this slide says, our children are just worth running upstream for. We're excited about helping them by creating safer, healthier, and more connected communities for our youth. Next slide, please. Thank you for your time, and we want you to connect with us. If you have any questions, please scan the QR code. Email any of us. You can email me directly if you'd like as well. Included in the slides that were provided, there's a guiding principles of the Icelandic model. That's what this Communities for Youth is based off of. It's the Icelandic model if you're familiar with that. And then there's some more Boise specific data included in that as well. And that concludes what I have. So I share with your
Certainly. Any further comments or questions from?
Thank you. This is a
Okay.
big deal, really big deal.
Thank you.
Thank you. I appreciate it.
We might be halfway through the agenda. Does anyone feel we need to take a pause or should we keep charging? Keep going?
Charging.
All right. So we are on to solid waste legislation conversation with Director Tutu.
Okay, thank you. So you recall we had discussions around non-municipal solid waste facilities, and somehow the transfer stations got tied in with that. And as of October 20th, for all the reasons we talked about, the complexity of the non-municipal solid waste transfer stations, our preference was to pass that back to DEQ. And for them, it was all or nothing, all non-municipal or none. So we chose the all option, which took out the transfer stations also. So we discontinued our oversight of those facilities on October 20th. There has been discussion for at least a couple of years around the Idaho Solid Waste Association's interest in removing the public health districts completely out of the solid waste business as far as regulatory oversight and technical assistance, to essentially consolidate it under one agency, the Department of Environmental Quality. So their executive director came and spoke at the Idaho Association of Local Boards of Health annual meeting that we had here in October. And Jess Byrne, Director Byrne from DEQ, they're not like taking one position or another, but more concerned about how does it get funded. But that's been our issue too, because we don't charge, we don't collect fee revenue for that. So we've just covered that cost with essentially now the county contributions to the health district. So this is more just awareness. We did make the decision that executive council, which Betty Ann is our representative and trustee, but the executive council made the decision to hire Mike Kane as our legislative advisor for this legislative session. So I feel pretty confident he's really good. He'll stay on top of it, be monitoring legislation. and then providing those updates to both the district directors and the executive council members from around the state. So the hard part is the meeting frequency, which you'll be voting on our calendar year schedule soon. No boards of health meet frequently enough to, for example, we don't meet again until February. So Betty Ann's going to have to make decisions on behalf of this board as far as, guidance. What do we do if this comes forward? From my perspective, that's fine. If that's what they choose to do. And then we'll essentially be out of that part of our business, and then DEQ will take it on in its entirety if the legislature will move forward with it. So any questions about that? Okay, so this be kind of that next step where we're District 4 out of non-municipal solid waste oversight, and this would be all non-municipal and municipal solid waste statewide if this were to come to be. And I don't know what the odds are of it passing or not, or what the opposition is, other than Director Burns' concern for funding. Okay. All right.
Any thoughts? I just, like I said, we talked about this a couple of months ago. I would rather, as a county, rather deal with Central District Health and DEQ.
Mr. Chair, that's exactly what I was gonna say. While I support the reasoning for why we're moving forward with this, the challenge for the counties, we had really good support from the public health district. More communication, just more streamlined, and I have concerns moving forward that transfer stations won't get the attention that they need.
Mr. Chair. And that's something, I appreciate that feedback. That's good to hear. And that's, I guess, Betty Ann, you and I can represent that perspective, because the truth is, and Brent's here, and of course, Curtis, Brent's he's oversees our land programs like septic systems and this kind of work, is what I think could be clarified in rule would be that non-municipal solid waste or the transfer stations be redefined. And that would, in rule, versus taking us out, and we were all good with continuing to do that and understand the reasons why, what both of you have just shared. So that's something we haven't really talked about, but that would allow us to re-engage with the counties with transfer stations versus remove our involvement completely. So.
Well, and as Russ pointed out, our state meeting, the DEQ personnel was there, and their main deal was they don't have funding and they don't have staff, so we get nothing. Lack of response.
Chairman, I can go on and on about how unsatisfied Elmore County is with DEQ. And we've made it clear to them as well, which may become more of a litigation aspect for us, but Central District Health has been amazing with all our issues over, our private landfill, but and I don't know what the solution is, because they've never had funding and they never give us the support. So, it's kind of the mantle has been on Central District Health with actually no resources monetarily. So, sorry, but it's been your job. I don't know.
Yeah.
Mr. Chair, I think, all the counties would prefer to continuing giving these county contributions, and you guys keep this. That you guys keep the transfer stations. We have big concerns. We heard from Director Byrne. They don't even have enough staff to do what they're supposed to do right now, and then add on more. I think it's really concerning for the counties. So I don't know if you need extra help with the executive committee from us writing testaments or what, but we would prefer it to stay under the public health districts.
Mr. Chair. I have heard there's a number of counties, just talking to the other public health district directors, that's counties, commissioners who serve on boards have voiced that same opinion. So something that I hadn't really thought about, but I think it could be to go back and, because it's in rural, right, where the transfer stations are defined as non-municipal.
That's correct, yes.
Is to go back and work with DEQ. They'd have to lead that, right? Their rules to make that change. They might prefer that. I mean, we're out, and other districts have talked about getting out of the non-municipal side. And the deal is, it's not transfer stations, it's the more complex land application and industrial waste, and you just go to DEQ and try to get, information from them, but those are, I think they're all private, right? They're all private statewide that have those kind of operations, so it kind of didn't make sense for us to be involved because we don't have the expertise, but we do have the relationships and expertise for municipal and transfer stations, which handle municipal waste. So it's just a path we could go down.
And Mr. Chair, sorry. I think we're seeing a trend where the counties aren't given the option to choose what they see best fit for our organizations. So I don't know if there's anything you think we could do as counties, if we could send a letter of request to DEQ or a letter of support or make phone calls.
Right.
But we all believe that these decisions need to stay with the county rather than the state, and maybe we can help to push that forward.
Okay, thank you. Yeah, we'll talk. Good. Okay.
Any other comments about trash?
It takes up more time than you think.
All right, if not, then we're on to the next subject, which is the letter regarding public health district funding and the home visitation and process back up.
Thank you, Mr. Chair. So when I think about the two probably biggest issues we have coming up with this legislative session, I thought it would be good to send a letter with the supporting documentation to all the legislators within our district, and there's a few that cross district boundaries, like share with Public Health District 3. They're certainly on the same page when it comes to the 393801 and the funding for our home visiting program. And so this is an action item. This is just one idea. You may choose to make some edits to this letter or prefer just go out under Dr. Birch's signature or all of your signatures, not mine or mine, whatever you want to do. So this is kind of it. There's some sense of urgency with this because it'll be January before we know it. And like to get this in front of our legislators, and then I can certainly have follow-up conversations. You can as well with your respective legislators in your particular areas that you are representing. But so the first issue is since 2016, the Idaho legislature has appropriated basically no less than $1 million per year to the public health districts. That's statewide for our home visiting programs. Essentially, it's parents as teachers and nurse family partnership. It got all the way up to $1.6 million. And then we had worked with the legislature to allow home visiting services to be covered by Medicaid, which is a big deal, right? Why use 1.6 million of state general fund exclusively when we could take that money and use it as match for the federal drawdown? And that took some time, but we got there. And when Laurel was presenting the budget, you could see the revenue coming in under home visiting. And that's awesome because that, when you talk about the sustainability and aligning funding with where we're heading, this is ideal where we can do work in homes, bill Medicaid, and have that help support. It doesn't support it in its entirety. So then when House Bill 316 passed and went into effect, the legislature quit providing the general appropriation to the health district. So we worked with the Legislative Services Office and they said, well, probably better just to have this money go to health and welfare. JFAC would write appropriation language to say, don't take a dime out of it. You give it to the health districts and you divide that money up according to what the Board of Trustees decides as far as the formula. And it worked great until now. So the state is a little short on cash and they've been asked to do a 3% permanent holdback. And I don't know how long, not that long ago, we had no idea that this was going to be considered, and we get a letter emailed to us from the Department of Health and Welfare to the district director saying, hey, heads up, we're going to cut the $1 million out of our budget, health and welfare's budget, to help them cover their shortfall to remove the money that the legislature appropriated to them to 100% pass through to the public health district. So of course we're concerned about that, right? That $1 million will have a pretty big impact on our ability to continue to do the good work that we're doing. I'll just put it out there. There's Families First funding, and I don't know a lot about it, but that was kind of health and welfare's conversation about. I think that might be the solution to make up this shortfall, but the communication from them has not been, well, there really hasn't been much, and we've been reaching out. I keep saying I mean the district director said, hey, what's the plan? We'd like to know, is this going to make up that $1 million shortfall? Should JFAC remove that $1 million from health and welfare's budget? What are we looking at? And they have to set like a reimbursement rate, and it's based on, as best I can tell, families have to meet certain risk criteria, and you have to do the work in front to cost, and then you essentially invoice health and welfare, and then they pay us. So having nothing I should say in writing, nothing even verbally communicated to us as of December 19th, it makes me concerned that the legislative session will end and we don't have a solution. And on July 1, our district will be short about $173,000. So
Is that our portion of the $1 million?
that's right. Yep. So, and when you look at all the state general fund we receive for like STI, EPI, and this is more than half of all state general fund that we receive now. So that's where, like, I included in there the action. I mean, if you want to take 3% out of it, we can do our part. We'll figure it out. $970,000 would be much better than $0. So that's the first part of this letter. And then the second part is related to Senate Bill 1329, which requires parent guardian authorization before a minor can receive health care. And when Heather spoke about mental health, that's also a really big issue for mental health providers and just healthcare providers, primary care providers, is to provide any type of services, including the 988 suicide hotline. If you're 17 and you call in, they can't help you unless you provide parental consent. So that's also a public health issue. I guess we've kind of really focused on this because this is what we've been doing for over 50 years. As far as if you're 14 to 17, the law 393801, which is still in the books, allowed us to provide care for communicable diseases without parental consent. And I've talked a lot with our staff. Beth's team is we always encourage parental consent for minors, but there are circumstances that that's just not practical and feasible. Also worked with some of Curtis's team on the EPI side and thinking about, well, what's the impact of this going to be besides, thinking about it, well, if you can get parent consent, you get access. If you don't at any provider. This isn't just a public health provider issue. So chlamydia is the most common reportable sexually transmitted infection. So just looking at that, what's the impact been? So we had a bump down in COVID, you know, looking at the last 5 years, bump down with COVID, people weren't accessing care anymore. We lost our money to do ours, all 7 health districts, funding to do STI education in our schools. So that money went away a couple years ago. And you see a further decline in the number of reported chlamydia infections. It affects all the STIs, but chlamydia, because it's such big numbers, you can really see the trend. So since 2020, this isn't like whether a doctor reported it or a nurse practitioner. These usually come from labs and are required by law to report it. So it's not, is it being underreported? It gets reported. So we've seen a 67% decline in chlamydia reported cases among 14 to 17-year-olds in the last 5 years. And those of you who work in medicine understand the problem is pelvic inflammatory disease with chronic pain and infertility. And the other point that I learned as we were working through this is, and it's a little lower for men or boys or teens than women, but 70% of the infections, chlamydia infections, are asymptomatic. So unless you get screened, you don't know you have it, and it doesn't stop the health consequences. Besides, it's a communicable disease, which is our kind of our core business, right? To prevent the spread of communicable and infectious diseases. So this is a really big deal. To me, I think we're going to see some serious consequences happening in the fairly near future. This isn't something that you get an infection untreated and when you're 50, you get pelvic inflammatory disease. As I understand it, to be within weeks of, I guess to you, within weeks of not getting treated, you start developing some of those symptoms as early as weeks. So I would like to work with our legislature. We have our resolution that was passed by the Idaho Association of Local Boards of Health that go into more detail on what I just shared with you. And I'd like to get it changed this year. It's been since July 1st of 2024 that these services have been made no longer available throughout the state of Idaho. And what we're asking is to not expand what we've been doing. We're asking to do what we've done for over 50 years. And that law, by the way, was unchanged since 1971. So the letter is before you if you like the letter, or if you'd like to sign it. If you'd like to make some edits to it, we can. If you would like it to go on under different signature, good with that too.
I like it.
I would like to point out that in kind of dovetailing in with a subject that's going to come up in the agenda in a little bit, there are things in the current media. And this article, this December 3rd article, Idaho doctor urges change to parental consent law. And Senator Anthony is aware of this subject, and they're already having conversations already, or I mean, through the outside the session about this issue. And so I mean, I'm not saying it doesn't hurt to reiterate, but I think that there is an awareness of the conflict or the challenge with if we supersede or not supersede, and that sort of thing. So I think that is the good news, is that there's already conversation being had to address this. But so this is before us. If I'm signing something, I prefer to make it clear that I'm signing as
as a result of a collective decision that we have all made. And if that's the will of the body, then that would be fine. So in light of that, we need a motion to emotion, however someone sees fit to approve this letter and send this letter or revise this letter, whatever the board sees fit.
Mr. Chairman, I would ask one question to the board. It's on the action on the second one. Should we change that to be more in line with the resolution, the last line of that? Seek clarification on whether or not code 32-15 supersedes, just a question. I prefer the language of the letter. I thought maybe if they were more aligned with each other.
Can you restate that or point me?
Yeah, so the action item on the second topic. I was just wondering if it would be better to change that language to the last whereas, or therefore it be resolved. Resolution.
Mr. Chair, I can speak to that if you'd like.
Yes, go ahead.
So when this board passed the resolution, it was language like what we have in the letter. And after much discussion, those who were in attendance of the annual meeting, it got to asking the question, is it superseded or not? So if the answer is yes, it supersedes it, that kind of ends the conversation. There's no action toward confirming, like when we originally wrote this resolution, which we did, ran it by the board, it was to support essentially having 393801 still be the law. But that didn't end up making it into the resolution. Those of you who were at the meeting, you could maybe speak a little bit to that. I mean, if I have my preferences, but my sense of urgency from a public health perspective, I'd rather work toward confirming that it does rather than just getting the question answered and then we wait another year, presumably, before we would try to move forward. And I think the more time that goes, maybe the less likely it is to get it reversed or clarified, but that's up to the board.
I mean, that's fair enough for me. I just thought maybe it was better. It basically says the same thing. It's the same point across to.
Yeah, we had Mike King come in and do some wordsmithing.
Yeah, so Mike has drafted legislation and shared that with the executive council for that section of Idaho code that he thinks will work. And we're kind of ready to go. And and the good thing was I felt like the executive council was supportive of moving forward with
Absolutely, I
that.
felt like they were too,
Yeah.
unanimously.
Yeah, unanimous.
Any other thoughts? Comments? Motions?
I will go ahead and move that we submit this letter in support of our positions for the public health department.
I second that motion, Dr. Cole.
First, second, is there any discussion on the motion? Then all in favor of the motion to submit this letter as written without amendment, signify by saying aye.
Aye.
Any opposed? Seeing none, the motion has passed.
Thank you.
All right, and then. So that completes that subject. Yeah, we're going to hear from Beth on some clinic services updates. Oh, he's already over there. Okay, take it away.
Okay, well, thank you, Mr. Chair. We'll just get started and talk through where family and clinic services has been over the next year or last year. Dustin, next slide, please. So I want to start us off and talk about a family's journey through Central District Health. And I'd like to introduce you to a young first-time mom named Maria. She connected with Central District Health early in her pregnancy. She heard of our programs from a community partner that our outreach coordinator had presented to. And her first program she met was our nurse family partnership. She received consistent prenatal support, learned what to expect during pregnancy, and built confidence as a new parent. The nurse home visitor then helped her understand that she was eligible for WIC and helped her enroll so she could enroll in WIC so she could receive nutrition education, breastfeeding support, and help her and her baby thrive. After delivery, Maria then shared that she was vaping to manage her stress. Her nurse connected her to the diaper program for tobacco cessation through our health policies and promotion team, helping her reduce and eventually quit her tobacco use. Maria relied on our health clinic for well child visits, immunizations, developmental screenings, and postpartum reproductive health, so she could determine when she was ready for her next child. As her daughter grew, Maria transitioned to our Parents as Teachers program, learning strategies to support early learning and school readiness. Throughout her journey, our community health worker helped her navigate housing, food assistance, transportation, and other resources that she qualified for. Once her daughter was old enough to reach school age, Central District Health continued to reduce barriers by providing school-based immunization clinics and dental health checks. These services at the school ensured that she stayed healthy and up to date on preventative care without Maria needing to miss work or arrange transportation. All of these coordinated services helped Maria build stability, plan for future pregnancies, and raise a healthy, thriving child. Further demonstrating how an integrated services support family at every stage of childhood and setting the stage for future generation. Now, while Maria is not an actual story of one of our parents, she is representative of all the families that we serve, whether they see just one of our services or all of our services. They all help support them to create healthy futures for their children. I'm going to talk through what our progress, our successes, risks, and where we're going in fiscal year 26. You'll hear things that were talked about by Laurel in our strategic plan, some of the risks that Russ just talked about to our programs as well. Next slide. So we'll start talking about our nurse family partnership program. Over the course of this last year, we've doubled our team to 4 nurse home visitors, building a capacity for us to see over 100 families. We're expanding into both Boise and Elmer County this year, as well as continuing to see families in Ada County. We're really excited that we are able to have our first full cohort graduate this May that completed the full 2.5 years of nurse family partnership. The risks that we see within this program are really focused on the state home visiting that Russ talked about, as well as the 4% Medicaid reduction. Over this next year, and already, our team's been participating in a research study as well as a pilot. The research study is focused on cardiovascular health assessments, and this pilot is on validating a new tool for assessing parent-child interaction and attachment. These were 2 things that our team was sought out to participate in based on how well they have meeting fidelity standards and growing their program. Next program I'd like to highlight is WIC. And I want to start off by thanking you all so much for the support that you've given to our WIC team in particular, especially around the raises last year. This significantly improved our retention and our morale among that team. And I'd say they are in so much better of a place than they were a year ago. This last year, they have hired 8 new staff, 6 clinical assistants, a supervisor, and a dietitian, which is really allowing us to grow in our participants. We have focused on the staff morale so that we can make sure that we have that stability to continue to see those participants as we expand. We've collaborated with our public health and preparedness team to look at utilizing GIS data to see where do our participants live so that we can make sure that when we do mobile clinics or offsite locations that we're going to places that meet the needs of our participants. And the other thing I'm excited that they implemented was walk-in Wednesdays. Every Wednesday, someone who wants to participate in WIC and join for the first time is able to walk in and receive access to care right away rather than needing to wait for a scheduled appointment. Risk that the WIC program has had, as you're all aware, the government shutdown significantly impacted WIC these last few months, where our team felt the stress of not knowing what was going to happen to their program and when it would be funded. I so appreciate the forethought that this team has had here to make sure that we could go in and tell our team that we're okay. Financially, we have reserves in place so that we can support you while the government shutdown is happening and until funds are restored, which was, I think, a huge stress reliever for a lot of our staff, especially some of the new staff who had just joined. I think they had lots of questions of like, I just started this job, am I going to be able to keep it? Other risks, we have quite a few long-term WIC employees that are getting closer to retirement age. So we're going to be potentially in the next year or two seeing some of that transition and using some of that long-term expertise. This next year, we're really focusing on growing our participants as well as making sure that we're meeting them in the communities where we are with them. The thing you may be really excited to hear, and our team has been going through training over these last few months, is a change in our food list that goes into effect in April. It's going to allow some different proteins like tofu and tuna in all categories and corn mesa flour, as well as reducing sugary juices and substituting with fresh fruits and vegetables, and reducing infant cereals. All right, next slide. Okay. Next thing I want to talk about is our clinical services, which includes our medical clinic as well as oral health. In this last year, we were approached by someone on our health policy and promotion team that there was a need in Idaho City, that there was no medical services there, and what could we do? We quickly met with them, looked at what was available, and they connect us with the school district that had an established medical clinic in the past. And I'm happy to say that we are now going to Idaho City 2 times a month to provide those services. We are building our relationships, developing trust in the community, and we're starting to see more families walk in the doors. So we're really excited about that growth. Our providers, our nurse practitioners are growing in their skill set around providing inductions. So people getting started on medications for opiate use disorder. So we're really hoping to see continued growth in that program and the utilization of the opiate settlement funds. We continue to see strong patient satisfaction survey results and steady growth in our patient participation at both for our nurse practitioners and our medical provider. In surprise to us this last month was we were awarded the Title V subgrant. And I say it was a surprise because initially we were not selected. We were in 4th place, and one of the selectees decided not to take the money due to the requirements. So that has secured funding for this fiscal year as well as next fiscal year for reproductive health services. Our oral health team. As you may have seen when you walked in, the cargo van out front has some great kids on there with teeth and toothbrushes. That has been a huge win and a win that is supported from your decisions on the board. That the oral health team is essentially bringing a pop-up dental clinic to these schools, which involves a small child-sized dental chair and all of the supplies. It was a huge burden and a job to satisfy for our team to bring those things in because they were heavy and bulky. So now with the cargo van, they're able to easily access, bring that stuff in and get set up. And I went and visited a few months ago, and it was just so cool to see the excitement from the kids around getting their teeth cleaned, meeting with somebody. One little girl was like, my mom doesn't take me to the dentist anymore. She doesn't have time. And I'm like, but she allowed you to come here? And she's like, yes. She was so excited. And then the little ones who were scared and nervous, and how well our oral health team did to calm their fears and help provide them with some of that preventative dental work. And that program, it just continues. Oh, yes.
Mr. Chair, and Bethany, if I may interrupt, are you hearing any conversations about the fluoride treatments?
We haven't heard. Sorry.
The controversy around those.
I have not.
I see some states are outlawing fluoride. Just Just a side note.
Yes,
Something to
that's a
think
great
about.
question.
Think about.
Risks to our medical and rural health programs, similar to our other programs, potential reductions or loss of state funding, the reduction in the Medicaid reimbursement of 4%, and continuing to see the impacts of Senate Bill 1329, that's the parental rights law that you just talked about. That's the next slide, please. So this fiscal year, we've been focusing on growing our reach around our medications for opiate use disorder, growing our clinics and getting more participation in our clinics. Our oral health team has been just starting a needs assessment and feasibility study around how we move into long-term care facilities. And is that the right thing to do? Is that a service that we need? And how can we support it and make it a viable program? As well as exploring additional partnerships with boys and girls clubs and ways to support homeschool children. This is our next home visiting program. Again, with your support, we have been able to grow that team tremendously in this last year. So since last December, we've added 4 additional Parents' teacher home visitor, and a 5th home visitor to Valley and Adams County. Really excited to see how much Crawford, who's our home visitor in Valley County, has been able to promote and grow that program from nothing in this last year. We're going to continue to have our rural outreach and making sure we really focus on growing our services in those counties, Elmore, Boise, and Valley. They have great partnerships with our Boise Police Department as well as our libraries. As well as same risks for this program is all around the funding. The 4% Medicaid reduction impacts them, as well as the potential loss of that state questioning funds. And for this next fiscal year, as I think I just said, they're going to continue to just grow their full caseloads. Our last nurse home visitor joined us sometime in November. So we have capacity to keep growing and get us up to, when they have full caseloads, 136 families across our district. And our last small but mighty team, our outreach and community health worker. Our outreach coordinator was tasked with growing our programs this year, making sure she talked about our clinic services, what do we do in WIC, and she has moved forward so well. She's developed lots of community partners, spends all of her time talking about our services, how to get connected to them. And I think we're starting to see more referrals based on that work they've done. Some new subsets of populations that we hadn't been seeing as much of were just as involved, and people that were involved in reentry programs, now knowing that they can access services through us. Our community health worker has grown to maintain our community closets, where we have donations for different clothing, hygiene products, shoes, so that families can get the needs that they have free of cost. They can just come in and have them whatever they need. And then she's doing direct work with our patients as well. She gets referrals from all of our programs to help families get set up with disability, Medicaid, child support, their passports, and is really learning how to navigate those complex systems so that she can help support the families on an individual basis. The biggest thing they've identified as risks, and really it's a risk to all our patients, is transportation. How can they get to their appointments and have to make sure we can serve them, whether that's here in Ada County or in our rural communities? And what type of service ways can we help meet them where they're at? Our home visiting programs do a great job at that, going to people's homes, but can we do telehealth? What can we do with partnerships in the community, like Lyft or Rights to Wellness? So we continue to work on that. Next slide. Throughout this next year, they're going to continue to focus on that growth, meeting more community partners, talking about our programs, making sure that the different coalitions know what we have so that we're able to continue to serve the most vulnerable people in our programs. As we wrap up, I want to bring us back to Maria, where we started, and talk a little bit about how our services in our family and clinic program help support someone from pregnancy through school aged and into adulthood by providing coordinated services through Central District Health. Because our services are connected, accessible, and timely, they're able to raise healthy children, reduce preventable risks, gaps in care, and plan for their future. The outcomes that we see are going to create stronger families, which in return create stronger communities.
Yes, Mr. Chair, and Beth, on our home visitor that supports Valley and Adams County, do we cost share staff time because Adams is in District 3?
We do not. We have an agreement with District 3 so that we can support the families that are right there in that New Meadows area. And we also have the same with, that's wrong, but the Grandview community right out of Elmore, so that we can support them as well. So we have an MOU in place to provide those services, but there is no cost sharing.
Thank you.
Any other questions, comments? All right, seeing none, very good. Thank you, Ben.
Yeah. Great program.
All right, next, vote on the audit process. Laurel is back up again.
Thank you, Mr. Chair. This will be a very quick item. So at the last board meeting, Jordan Swigert came and presented on the audit report for FY 23 and 24. We had it as an information item, not an action item. So this action item is to approve of that report and to move to an annual audit rather than every 2 years. So I would ask for a motion to both accept the audit and to move to an annual frequency rather than biannual.
Mr. Chair, I would move that we accept the audit report and move to a annual audit. Yes.
I'll second that.
Second, Betty Ann. All right, any discussion on the motion to move to an annual audit period? No discussion? Then all in favor, say aye.
Aye.
Any opposed? Seeing none, motion passes. Very good, thank you. You're right, that was quick. Next thing on the agenda is a quick conversation about, I don't know, something that hit me. There's a lot of things in the news, health-related things in the news. And I thought it might be a good opportunity to schedule a few minutes or leave a few minutes in a meeting, maybe 15 minutes or something, to discuss a current topic that might be health-related. After all, we are Central District Health. And so, for instance, Betty Ann brought up fluoride. And maybe there's something in the news about some areas banning fluoride, others having a different opinion, but I thought it might be a good idea to have conversation about topical health things. I ran across something called the Partnership to Fight Chronic Disease, and it's a nationwide program, and they have tailored information about chronic disease, and I printed out the Idaho statistics. And, it talks about projected total cost of chronic disease from 2016 to 2030 in Idaho is $219 billion. And as a health entity, maybe it would be wise to look at some of this information, have conversations about some of these, like for instance, this subject, the projections of cost and how can the health district be involved in possibly reducing the incidence of chronic disease. And so that as an example, what I would envision possibly spending a few minutes on in future meetings. I cut out a couple of other studies, flu shot study canceled. More Idahoans getting sick from raw milk. Maybe that's a conversation. There's numbers of topics that we might address like that at a future meeting. And I'm open to the board's thoughts or opinions on something like that.
How would we pick what topics they are, or would be general discussion on whatever anybody would be bringing?
The logistics that I thought is maybe if we had a certain deadline prior to the meeting, that if someone ran across a topic that they might be interested in or might think it'd be good to discuss something that came up, like, Betty Ann reads an article about fluoride and we submit it in advance, maybe with a possible link to the article or the story, and then have that disseminated. And if we did a couple of minutes of homework and came and, discussed that particular health and wellness subject at that future board meeting. Something akin to that.
Yeah, I can see the positive, maybe opportunities for something like that, especially if we were to come up with a subject that could be put on our website for public education.
Mr. Chair, maybe this is just a general comment. Maybe I've been in land use issues too much with LUPA and some of the concerns, but would there be any concerns that if we talked about a subject and then we had to make a decision at a later time, that that would affect our decision like it does with land use, like ex parte, that we're all talking about it as a group without making a decision? Like it's going to taint our future agenda items? Possibly, or is that not something that is a concern outside of land use decisions?
To me, it's informational.
Yeah, we wouldn't be, my opinion of this idea wouldn't be an action item. At that moment, we discuss it, and it would be a corporate public discussion. So I don't think we'd be in violation of any open meeting things or anything like that. It would just be, maybe taking a subject like I brought up earlier, apparently there's an interest in bringing back the president's fitness testing. And maybe that's something we talk about. Maybe if we've got people going into the schools and doing things, can we facilitate or help improve the participation in assuming they get it rolling again and whatnot, but just as an idea, can we be involved in some of the, topical current events regarding health and wellness?
Chairman, I'm thinking that the intention is to maybe start initiatives or just informative. I guess maybe if there's something that is maybe controversial that might come before us, maybe Russ can kind of screen those. But yeah, that's maybe not a topic that we need to be involved in. That we're gonna have to make a major decision on later. You never know, it's day and age.
Yeah, I guess I don't, on the land use, I guess my mind went to open meeting laws. So if we just have an informational item, talk about fluoride, and then the next time we get together, you all say, hey, we probably ought to do something. Then the next time we publicly notice it, make it an action item, if that was the preference of the board, I think we'd be fine doing that. But I don't know what the nuances of the land issues are. I mean, if you have a conversation outside of the meeting and 4 of you are there, and if that becomes problematic versus having a conversation at a public meeting, I think we'd be fine. And then later, if you chose to take an action on them, action on that topic, you at least have had the discussion at a public meeting, and then later have it properly noticed as an action item. That's what I'm envisioning.
And that, in a nutshell, is how I perceived it, or came up with the idea that maybe it just gives us a little diversity to have conversation about current events in the healthcare world.
Chair, I think it's a great idea to be a little more transparent, open with the public. They can get a sense of this board's thoughts on current issues.
Mr. Chair, Dr. Cole, I like the idea because obviously you brought up the fact that we're a health board. And so just bringing these topics that affect the community's health, I think is a a critically important idea. And, as Russ just said, bringing information forward just to discuss and dialogue, I think is a wonderful idea. And then if we want to make an action item for the following meeting, we can. But I think it in this era of awareness of health and health issues, I think as a board, it would be a very good educational opportunity for us. Thank you. Over.
So right now, this isn't even really an action item, other than maybe if we had a consensus that it's a reasonable idea, we do a test run February meeting. And me personally, I would love to have the input, and if individuals run across a certain subject or you deal with something at the county, that we float that idea back and pick a couple that we might talk about at that upcoming meeting, and just have at least a week or something deadline prior to the future meeting to submit your proposal for something you'd like to discuss. Good. Okay, very good. All right. Then the next and final published item on the agenda is a conversation about those upcoming meetings that we might deal with. So, did everybody look over the proposed dates, schedule, and are there any overt conflicts or things that you need to consider?
I was gonna say on that, sorry, Mr. Chair, on the Boise County scheduled meeting, probably will happen here. We don't have a very good place. I mean, we could make it happen up there if everybody wants to go there. Probably easier just to do it here.
Sure. So that is the budget.
Does there have to be there?
No, it doesn't. It was what we decided was to diversify our basically, we always meet in Boise. So it's been a while. I just wanted to give you the background on it. I don't know how many years ago, some of you may remember that we decided,
Well, at least an advantage.
yeah, that for the once a year to kind of rotate it around the county so that you all can spend time like in Valley County or Boise or Elmore County. So that was the whole purpose.
No,
of
I
it.
appreciate
Yeah.
the be included, but we don't really have a great place to host a meeting with, and then you have to have all the board chairmans, right, attend that meeting for 5 minutes.
Yeah.
It's just
Or they delegate it to.
long drive out there for them for that. I think it's probably just better to schedule it down here. In my opinion. But if you guys want to come to Boise County, we'll figure it out.
Yeah, it's up to all of you. So if you prefer to meet here instead.
Up to the host.
I think it's up to all.
I would say it's just more convenient and easier to have it here.
All right.
I have conflicts in February and March. I will just have to probably do them virtually unless we can change those dates.
All right. Well, then I guess if Commissioner Tucker, do we need a motion or to?
I'd say you need a motion to approve the calendar with the May 8th meeting being in Boise. And then with Commissioner Caldwell's conflicts on February 20 and March 20, if you wanted to look at a different date, we could. And then you just make that part of the motion to change those two dates. And virtual's fine. Cole joined virtually today, so if that would work, it's
Yeah,
no
that's
problem.
fine with me.
So
It's not that you're completely unable.
The March date is more iffy, but February, oh no, I think I fly to DC that day, so that I'm not available at all on that day.
Good to the day before, right? You don't see any issues with that date, Corey?
The day before on a
Like,
Thursday.
Or the week before.
Well, the day, if you wanted to do it on a Thursday, but if that doesn't work, we could do it actually, maybe the week before. What's a holiday? You're not here for, can't do it the week before. The week after is clear for you and everyone, but. Sure. For the day before, or stay February 18th.
Fridays are gonna be my better day.
I can't do the 19th. I have school for training.
19th, that's a Thursday. Yeah,
Do you want to do the 27th?
Thursday's an office day for me. So we're looking at, which one was it? The
February. Friday, February 27th, instead of Friday, February 20th.
What about like Friday, February 6th? Hard for budget. Oh, okay.
You should have it by then, but it's 5 business days after the end of the previous month that we have that available. If it's not, we could always do the month prior. So if that works out better for everyone, just be aware you might be missing a month of budgetary data.
Sorry to be the challenging one, but that's NACO, so we have to go back, or someone has to go back.
It'll
be a conflict for, if it's that week, it'll be a conflict for as long as we're involved with NACO.
okay. So the budgeting issue on the 6th. So what is everybody else's schedule?
Mr. Chair, I'll be in DC on the 6th and unavailable.
So that's a distance between this meeting and the next. Is that an issue?
Possibly just with the legislative season.
Does anybody have a currently known conflict for the 27th
Are you talking February or March?
of February? Because that's when you have the real conflict, right? The other one you can zoom in,
Most likely.
likely. And you're in town on the 27th?
So I know.
All right. All right, so maybe then do we have a consensus instead of February 20th? It's the 27th?
Sounds good.
Okay,
So we got that change,
and the
And the-
location.
May 8th, the location change for your motion.
Is there a time change on the meeting?
Normal.
Regular, after the budget meeting, so 10:30, like immediately after the budget meeting. Oh, okay. Unless we move the budget meeting up. That's you.
Isn't this the same time that it was last year?
10, so it's at 10. Yeah, but that's, we can catch you like it.
Contend.
That's good.
All right, so
You want to change March? No, let's just leave it for now. I don't want to cause any more challenges.
all right, so with that consensus, do we have a motion to approve an agenda as we appear to have modified?
Move that we approve the meeting schedule for 2026 as we discussed.
All right, is there any more discussing about that? All right, seeing none, all in favor of this new meeting schedule?
Aye.
Aye.
All right.
Motion passes. That's the last official item on the agenda. I guess Merry Christmas, everybody. Joy.
Yes.
Merry Christmas.
Thank you. I believe probably Alicia was instrumental in this. And, but thank you to
Yes.
Just the
administration.
glass containers with the metal lids, Corey and Laurel were instrumental in that.
Oh.
Yeah, so. Okay.
All right. With that, adjourned. Thank you, everybody. Thank you for logging in, Dr. Cole.
Thank you,